Hi, everybody. We're going to get started. I want to leave lots of time, so not only for our presenter, of course, but for what is sure to be exciting discussions afterwards. So welcome, everyone. Today, I'm thrilled to announce our speaker, Dr. Joonwu Lee, for our weekly cardiovascular research seminar series. And I'm just going to keep reminding everybody that it's our 50th anniversary. I'm sure everyone knows and has attended our kickoff party and we'll continue to celebrate. But I feel like a talk and a topic like this today actually really does illustrate how far we've come as an institute from doing, surgeries in a basement with the most basic, at the time, very advanced technology, of course, to now using AI to make decisions about treatment, which I think is really incredible. And we'll have our presentation or our questions afterwards, as we've said it in the past. We are holding all of these in person, but for anybody who's missed it today, they are being recorded, so they can be watched later. So just in case, if anybody after you tell everybody about this great talk today, just let them know it is recorded afterwards. Okay, so it is my pleasure to introduce Dr. Lee. Dr. Joonwu Lee is the Director of Data Intelligence for Health, or DIH Lab, and an Associate Professor of Health Data Science in the Departments of Community Health Sciences and Cardiac Sciences at the Cumming School of Medicine at the University of Calgary, as well as a member of the Libin Cardiovascular Institute of Alberta and the O'Brien Institute of Public Health. He's got his PhD in biomedical engineering from U of T and a Bachelor's of Applied Science in electrical engineering from Waterloo. He's completed postdoctoral fellowships in medical data science at Harvard, MIT. And prior to being recruited to Alberta, he was, in fact, Ontario bred and at the Faculty of Applied Sciences at the University of Waterloo. So his primary research interest is in transforming health data from the various sources to useful information and knowledge. His research applies data science, machine learning, artificial intelligence, natural language processing, mobile technology, and biostatistics to several health fields, including intensive care, aging, and population health. And as you see from his title today, also cardiovascular medicine, much to our benefit, of course. And he's won numerous awards, including the Early Researcher Award of the Ministry of Ontario for his innovative science that he has been contributing. We are so lucky that Dr. Lee has joined us today in Ottawa. So welcome, Dr. Lee, to the podium.
Okay, so thank you so much for the introduction. My pleasure to be here to be speaking to you about some coronary disease topic. So just to start here, conflict of interest disclosure. I'm the CTO and co-founder and the major shareholder of Symbiotic AI, which is a spin-off startup from my research lab at the university. And this startup is commercializing the technology that I'll be speaking about today. I wanted to acknowledge my funding sources upfront. So we have major grants from Alberta Innovates ACE program and the CIHR project grant program. And we have also been supported by our medical school at the University of Calgary and the Libin Cardiovascular Institute. Yeah, so I mean, there was the introduction, but let me just add a little bit of meat about myself. So I've been a health data science, machine learning, and AI researcher for 20 years. I pride myself for beginning my career before the Coronary AI hype. So I actually remember what it used to be like when nobody knew what machine learning was and what AI was, and other than like science fiction stuff. So back then I had to explain what machine learning was to people, and now I don't have to do that anymore. So that's the changes that we have seen. And I mean, like mentioned in the introduction, I've worked on many different areas of health, ranging from public health to different medical specialties. My research experience in intensive care comes from my time at MIT. So I did my postdoc at the lab that developed the MIMIC database, which is a pretty famous public intensive care unit database, which is used worldwide. When I was there, they released a MIMIC 2. Now they're up to MIMIC 4. So there is the connection there. And yeah, so just like any other academic. I still do, but I used to focus a lot more on publication, getting grants and that kind of stuff that academics do. But then you publish papers and then they don't make any impact in the real world. So I kind of wanted to change that, at least for myself. So this is my goal, and I guess this is the goal for our entire teams in my lab and the startup as well. And in order for me to make this happen, there's the healthcare aspect, and I'm not a healthcare provider. I'm an engineer by training, so by definition, I cannot make this happen by myself. So we do work quite closely with quite a few clinician collaborators, quite internationally. And I put Dr. A.Y. Chung at the top because I'm here at the UHI. I had a meeting with him this morning too. It's always great to be working with him. And throughout Alberta and other countries around the world, we have a bunch of people that we work with. And we get their feedback on what we are developing, on a regular basis. So the problem that we are trying to solve is coronary artery disease. And the disease is massive. It impacts a lot of people worldwide. It's the leading cause of death. The treatment for the disease is usually, the decision between PCI, stenting, CABG surgery, bypass surgery, or just medical therapy only. And this treatment decision-making is straightforward in many cases, especially, less severe cases, single vessel disease and stuff like that. But it can get quite challenging in many cases when you have to deal with complex coronary anatomy, extensive comorbidities, and the unique patient preferences. And CAD is probably a disease that has been studied extensively in large scale randomized controlled trials. There are lots of large trials that have tried to answer this question of treatment selection. Usually PCI versus CABG in the older days, and now medical therapy only has become pretty important treatment option that clinicians need to consider. So there have been a lot of comparisons in RCT settings. But even with those, and there are clinical guidelines that tell you which treatment is probably the best one for the patient, we still deal with challenges in the decision making because the clinical guidelines are quite one size fits all. It's at a population level. In general, these treatments will be the better ones given the circumstances, but it usually doesn't consider the unique patient characteristics so in other words, it's not personalized. And clinicians, will speak to this. They will say, yes, the clinical guidelines don't fit my patients all the time. More often than not, actually, they don't fit. So they have to come up with some kind of subjective decision making. Anecdotal experience becomes important, and et cetera, et cetera. There's a risk score that's widely used in this space called the syntax scores, and there has been an evolution of the score itself. And these scores actually guide these clinical practice guidelines as well. You're supposed to calculate them, and then based on what that score is, it will guide which treatment might be the best option. But requires manual data entry. There's a web-based calculator that we all have access to, but you have to enter the data manually. And because of that, clinicians don't use it other than training purposes. Maybe you're a fellow and you're asked to explicitly calculate this 2 or 3 times just to get comfortable with it. And then after that, people just start to estimate what the score might be instead of actually calculating it. So there are, problems in terms of clinician adoption. So putting everything together, the problem that we're trying to solve is we need a better personalized quantitative CAD treatment decision support. And if you can get hands-on complex larger scale data set that capture this problem area and apply machine learning to it, then maybe we can come up with useful models that can try to address this problem. So our goals have been to develop Revaz AI, which is the name that we have given to this technology, which is a clinical decision support tool. And we didn't want to just stop at building the models and publishing the results and just be done with it because nobody will use them. So we wanted to, focus on bringing the technology to the point of care, integrate it with the EHR systems used at hospitals, and then really, go deep into the clinical workflow, like what are the clinician needs that need to be solved, and then after all of that, demonstrate that this technology actually improves something meaningful at the end of the day. And that's usually patient outcomes, maybe saves costs, whatever that may be. So I'm gonna walk through 4 publications that can sort of speak to our journey so far. The first 2 are the major ones, and I'm gonna speak to them in some detail. The last 2, I'm gonna spend a little bit less time, but they can still support our journey. So this paper speaks to the model development, and it's available as an in-press article in the Canadian Journal of Cardiology. And the data sources that we used to develop the models came from Alberta. So we used the clinical registry called Approach, which has been collecting data from all patients that go through coronary angiography in one of the 3 cath labs in Alberta. There's one in Calgary and 2 in Edmonton. And we linked the registry data to that NACRS and vital statistics. We actually linked to more other databases, but later on we kind of dropped them to make the models a little bit more deployable. In the end, we ended up using data from over 44,000 catheterizations from over 38,000 patients. It covers a span of about 10 years. And we excluded STEMI patients because STEMI is an emergent case, and they usually go straight to putting in stents. So there's no time for decision making. So we left that that indication out. And then we covered all 3 hospitals in Alberta that perform coronary angiography. So we have a complete coverage of the Alberta population in our data set. So the modeling itself, we aim to predict all-cause mortality and the 5-point MACE, consisting of myocardial infarction, heart failure, stroke, repeat revascularization, and all-cause mortality at time points ranging from 90 days to 5 years. And we started from a very large pool of predictor variables or features, as known in that machine. So we started with more than 12,000, so which is a pretty large number. And we also had 3 different sort of sets of features that correspond to different time points in the patient journey. So we have some models that can fire before angiography even takes place. We have models that use admin data and some other information that are still available before angiography. And the last set is everything, including data elements coming from the angiography itself. So those models cannot be used until angiography is completed. And we did that on purpose because usually the more features you have, the better prediction performance you're going to get, but maybe less likely in terms of deployability because you have to wait that long to collect all the data elements, et cetera, et cetera. So we wanted to sort of investigate that. We tried all kinds of different machine learning models, but the ones that we wanted to highlight are TAP-PFM models. I don't know if any of you are familiar with this particular model, but it's a tabular foundation model that's relatively new. And it has the transformer architecture, the same as large language models. And because it's a foundation model, even without explicit training using your local data, it already performs pretty well in the 0-shot and few-shot settings. And compared to more traditional models, TAP-PFM models performed a lot better in our case in most of the prediction tasks that we investigated. And some unique things that we did were we had a separate data partition just for calibration. Sometimes machine learning people don't pay a whole lot of attention to calibration, just discrimination. But we wanted to make sure that we hit this one right as well. Like when the model says there's a 30% risk, we don't want it to be actually 70% or something like that. That's way too off. So we wanted to calibrate as much as possible. And we also did an algorithmic bias correction and assessment with respect to patient sex and age. And because we had 3 sites in our data set, we were able to perform external validation. So build models using 2 hospitals, validate on the 3rd one that was left out, and then rotate. So that's what we performed. There are a lot of results in the paper. I cannot share all of them, obviously, but these are the main ones that I just want to talk about. The font might be a bit too small because there are too many bars, so sorry about that. But this shows the AUC results for the 8 outcomes here, all-cause mortality and MACE at 4 time points each. And the 3 data sets that I talked about are the different colors. So as you go from left to right, you go from using all features to using the minimum deployable set of features. And the minimum included is 62 data elements to be specific. So you can see that you know, pick any outcome and the cohort here, you see performance drops as you go from all features to less features in general, which is what we expected to see. But the difference is often quite small. And, you know, is that difference even clinically meaningful? That's the question. And given the magnitude of the difference, probably not in a lot of these different cases. Mortality is a little bit easier to predict. The best performances are in the low to medium mid 80s. The MACE outcomes are a little bit less, so they are harder to predict in general, which actually matches what we see in the literature, and they're more in the low to mid 70s. And most of the best models that are shown here are TAP-PFM models as opposed to traditional models. Okay, so that was the first study. So at this point, we have a model that has been externally validated, at least within the province of Alberta. So, you know, what can you do with the models? Well, the next thing that we looked at was the health economic benefits of using these models. If you were to simulate what might happen if the prediction information was available at the time of decision making, and maybe some of the treatment decisions were altered by the suggestions, brought up by Revaz AI. So that was this particular study. Recently, actually accepted and published, available as an in-press article again on MPJ Digital Medicine. Was a simulation study using retrospective data set. So there are limitations that come with that, obviously, but it's an attempt to show that, you know, if things were happening ideally, then like what would have been the economic consequences? So just to talk a little bit more about the simulation modeling itself, we did the Markov health economic simulation modeling, meaning that it's a probabilistic model. There are a bunch of different probabilities that go into the model, and it simulated what would happen for the patient if they were to receive a particular treatment option. And then we did that a lot of times just to, you know, cut through the uncertainties and variance. And then we looked at the results. That's, you know, basically what we did. We used a subset of the Revaz model development data set. And we made sure that we used I guess the majority of the data set to train the models. And then what was not used to train the models were used to see the effects of the using the models from an economic standpoint. So the primary analysis results come from about 7,800 test patients. And we used the actual patient data and the actual predictions made by these models based on those actual patient data. So each of the 3 treatment options was simulated 500 times, and we simulated lifetime. So until the patient dies in that particular simulation. Event probabilities, costs, and utilities were taken from the literature whenever we could, other than the ones that we're getting from our own data set or the model predictions. And we had three different scenarios. So the first one was going with the health economically optimal decision every single time, which is defined as the quality gains, so quality adjusted life year gains, converted to monetary terms, minus the difference in costs. And if that's within that willingness to pay threshold, which is $50,000 US per quality, then that's our economically optimal treatment decision. And we say, okay, that's the one that would have been recommended by our technology. And we know what actually happened to the patient because this is retrospective data. So that's the actual. And then we compare. So did the cost go up or down compared to the actual? And then did the quality benefits or gains go up or down, right? So that's what we looked at. And then scenario number two was, okay, we don't care what the cost is. We just want to improve qualities as much as possible. So no cost threshold. And then the third one was, well, maybe the physicians don't always follow what our technology says. And that's obviously probably true in a lot of cases. So let's assume that physicians won't go with what Revaz might recommend unless there's a quality gain of at least 0.2. So that was scenario three. So from the primary results, which is scenario one, the average cost saving per patient was about $23,000 US, and that's throughout their lifetime. And the average quality gain was about 22,000 per patient. And I guess what's most shocking here is 72.4% of actual treatments actually are altered if you were to follow the health economically optimal decision. So that's scenario one. There's no like a filtering or threshold going on. As soon as the model says this is the health, economically optimal decision, then we just assume that the physician just follow that. In scenario three, I don't think I have the number here, but that number is probably down to like 40% or so. It will go down as you might expect in scenario three. And the treatments shifted from the actual to something else in all directions. But the shift to cabbage was more pronounced overall. And now, if you talk to any clinicians in this field, they're going to raise concerns and questions and whatnot. If you're going to cabbage every patient, like how is it possible? No, it's not possible. So there's a surgical capacity limits. The patient may not even be a good surgical candidate, maybe too old, too many comorbidities, et cetera, et cetera. So some of those factors are not considered in the models because they don't have that information necessarily. And that's actually part of the reason why we conducted those three scenarios, just to play around with what might actually happen. But this is a big limitation of this kind of study, retrospective study. We are not taking into account all these like real life factors. But so the numbers that you see, you might consider them as the ceiling as opposed to what might actually happen in real life. And we saw that most economic benefits are long-term. So for example, if you switch over to cabbage, the upfront surgery costs will be high in the short term, but in the long term, when you look at the lifetime of the patient, which is often 15 to 20 years in this particular patient population, then they're going to have fewer complications. They're going to seek healthcare a little bit less. They are not going to need as many medications and so on and so forth. They kind of add up in the long term and then materialize into cost savings. Just to visually see the results. So these are the figures that we have in the paper. A little bit difficult to orient yourself to these because these are not like typical graphs. But on the x-axis, you have the optimal versus actual quality difference. So again, actual is the actual treatment that was given to the patient. And then optimal is what was recommended as economically optimal. And then on the y-axis, you have the same thing for cost, so cost difference. So the four quadrants are labeled, as you can see. So the upper right quadrant will be higher cost and better outcomes. And bottom right would be lower cost and better outcomes, right? And you see kind of like this diagonal line and all the data points which are patients are below the diagonal line, because that's the $50,000 per quality threshold. So we are actually, capping the benefits at that, or how much are you willing to pay to gain qualities, and that's the threshold. So all the patients will have to be below that threshold. So that's why you see there. And if you take the mean of all these data points, then that's the blue diamond right there. And those are the numbers that I quoted as the average values. And this is the scenario 2, second scenario, where there's no cap on the cost. So you are going to just go with the whatever treatment that maximizes quality. So everything is on the right side because quality can only improve under this scenario. But cost will go up because you don't have any cost limit. So that's why the cost difference is actually positive now, has gone up on average, but you gain a lot more on the quality as well. And then the third scenario, the quality gain has to be at least 0.2. So 0.2 converted to dollar amounts is 10,000 at the WTP of 50,000. So that's what you see on the at the vertical over here. So everybody is on the right side of that. And the mean is right over here in this particular case. The cost has gone down a little bit, and that's negative $1,900. And the quality gain is about 32,000 in this particular scenario. Okay. These economic results are quite important for health systems. So clinicians may not care about this aspect a lot. Patients will care about it from the quality perspective, but not necessarily from a cost perspective unless they're paying out of pocket, right? So different stakeholders will probably have different perspectives on, thinking about adopting technology like this. The third study I'm going to talk about here has also been published in NPJ Digital Medicine. It was a different approach using the same data set. So we used reinforcement learning to see if we can develop a model or policy that can tell us directly what the best treatment might be. So reinforcement learning as a sort of a suite of methods in machine learning is a lot more direct in terms of recommendations than, say, supervised learning techniques like prediction models, in that it will tell you exactly what action is the best one in that particular moment in time. That's what this is designed to tell you. But the prediction models can only predict the outcome that you're trying to predict. The user is supposed to take in that information and decide, okay, given this information, what is the best action that I should be taking? So it's a little bit indirect from that perspective. So this is direct, and I guess direct could be a good thing from a decision-making perspective, but it's also a little bit more dangerous if the model is off, because it's really telling you this is the treatment that you're supposed to get. Yeah, so reinforcement learning is the type of technique that's usually used to develop like robots and autonomous vehicles and these things that will just go into some kind of environment and then learn to do its own things. Has moved into other areas, especially health, in the past few years, and there are actually a lot of different reinforcement learning studies in healthcare now. But the nutshell is that you're trying to develop this agent which is autonomous, and you're gonna guide it to learn to perform a task in a real environment. And the way you do it is you actually let it take some actions in the environment, and then based on that action, something will happen, and the agent will go into another state, and based on that state transition, it's gonna receive certain rewards from the environment if it made the right action and the results were positive, right? If they were negative, bad things happen, then it's gonna get some penalties up. And then you record that over a long period of time, and you use that algorithmically to learn what the best way to make decisions in that particular environment. So that's the crux of it. Now, problem in our case is that because we use the retrospective data set, this is very difficult to do. You're actually supposed to do trial and error like this. So you have a robot that will just go out to the environment, actually do something, try to pick things up and whatever. And then you record the results, and then you do that a lot of times. But you cannot do that with the patients. You cannot just do trial and error with patients like that. So in our case, what we did was we took a retrospective data set, and then we did something called offline reinforcement learning, which is a sub-branch within reinforcement learning. Comes with lots of limitations because you cannot explore and trial and error like you're supposed to do. But there are certain techniques that can sort of help you overcome that limitation in retrospective data. So that's what we did exactly. And you have to set up the whole problem. So first of all, you have to set up the reward structure. And in our case, the rewards were based on the outcomes. And we observed each patient for 3 years. If the patient develops, like say, a MACE event, then it's not a good thing. So there's a penalty associated with that, which is calculated based on that. And the earlier the MACE event happens, the higher the penalty. Same thing with the death. And once the patient dies, that's a terminal state. The patient episode ends right there. And then the patient actually can have a happy ending if 3 years pass and then there's no death and no MACE. Then that's probably the best outcome that you can have. And then there's a reward right there. And then there are 3 actions that you can take a look at. And these are the 3 treatments that we've been talking about. So based on that, what we did was we used our data set, which is the same as the previous study. 3 different reinforcement learning models or algorithms that are available to us. And we developed 2 separate policies. One is the optimal policy using the data that we had. And we also formulated the physician policy. So this is what actually happened as we can observe in our data set. And then we compare these 2 policies and see which one is actually better. And there are some techniques that allow you to do that using retrospective data. So just to cut to the chase, again, there are a lot of different results in the paper, but the main results are that the RL policy, which is the optimized policy from a computational perspective, outperformed the physician policy. And up to 32% improvement was observed in expected rewards. The treatment agreement between reinforcement learning and physicians was only 20 to 26%. And again, even in this study, cabbage was recommended a little bit more than it was actually used in practice. So the same sort of feasibility questions come up, and which is also discussed in the paper. But then in this study, we did something else, which was the conservative Q learning. So that's a particular reinforcement learning algorithm that actually penalizes making recommendations that actually don't happen much in the data set. So it will penalize cabbage recommendations quite a bit. So we tried that, and there's a parameter in the model called alpha that controls how much of that should be taken into account. And at alpha value 0.5, the treatment agreement between the algorithm and the physicians went up to 68%. So at least this approach has that like sort of ability to adjust, how much of the recommendations you're just going to accept without considering how realistic that is. This study took a different approach, which is reinforcement learning. And then when you look at the final results, they actually line up quite nicely with the first study that I talked about. So a little bit more cabbage. The treatments that are actually being made don't seem to be optimal from a computational perspective. And what should have happened, at least again from an algorithmic perspective, does seem to be quite different from the actual treatments that were given. And then lastly, I just wanted to spend a little bit of time talking about this qualitative study. So just going back to technology is one thing. Maybe developing these models is probably the easiest part of this whole journey. Once you have a technology or models, how do you actually get them to be used by actual clinicians and patients and so on? So that's the hard part. So we did a qualitative study to understand the potential challenges and the facilitators of bring this kind of AI innovation into coronary artery disease treatment decision making. And we performed something called the World Cafe. I'm not a qualitative researcher. I learned a lot from my colleagues throughout the journey here. But it's basically a group discussion session where you have participants from different stakeholder groups, and you ask them questions, and then you let them answer those questions and discuss among themselves in a group setting. And we had quite a few different clinicians participating, cardiologists, interventional cardiologists, cardiac surgeons, and we also had a health system administrator, patients, as well as an industry representative. And a caveat here is that we wanted to perform one big World Coffee discussion, but 3 clinicians couldn't make it because of emergent patient cases. So we kind of had to perform one-on-one interviews with those 3 individuals afterwards, following the same protocol. It's a limitation of the study, so it's discussed in the paper as well. The 3 questions that we posed to the participants were these. So what is most challenging about revascularization decision making? How could an AI tool be integrated into the existing workflow? And what are the critical components of the AI tool that need to be considered when developing the tool? So some questions are quite broad, and some feedback did go a little bit beyond just the coronary disease treatment decision making. But there are lots of factors that actually are common. Doesn't matter what you do, what medical field it is, the same sort of issues and barriers and facilitators. So once we got the feedback from the participants, we did a thematic analysis and came up with these 5 themes. So evidence-based care, workload and resources, data requirements, tool characteristics, and the AI incorporation into clinical workflow. And then the 3 of the themes also had the sub-themes that emerged. All the details are in the paper. I'm not going to bore you with all the details here, but all the important things that we usually talk about, data privacy, workflows, do we even understand how the tool works and how the models were developed? And different stakeholders have different takes on these topics. So patients will say something quite different from clinicians and so on and so forth. So all these things came up. And just to share some of the quotes that stood out to me, these are some of the things. I'll just let you read for about 30 seconds. Yeah, so the top quote is just speaking to the practice variation, which inevitably exists because of the clinical guidelines not being like precise for every single patient case. And then the bottom quote is just speaking to the potential of AI-based technologies that might be able to find something in these complex data sets, and maybe we can use that somehow to improve our, our care. And 2 quotes from patients. And the top one speaks to patient preference. And the clinicians may not be optimizing, say, incontinence for every single patient until they get that input from the patient. But that tells you that like patients might be thinking about something else, as opposed to what the clinicians or even the literature might be optimizing all the time, which are always MACE, mortality, these like a hard clinical outcomes. And then the bottom one there, sort of a concern that like this is like too complex. I want to understand how the technology works, but like how do I understand it? Type of question. Yeah, so those are the 4 studies that I want to discuss today. I'm gonna start to wrap up here. So we have a really long journey all the way to real world clinical adoption, and then we also want to demonstrate the benefits. We are still walking that path. So where do we go from here? So the studies are, first of all, retrospective all. So we want to start to move on to prospective trials and clinical trials and whatnot. And then in order to do that, we actually need to bring the technology to the point of care, which requires integration with the information systems that are being used at hospitals. So all these things will take, as you can imagine, a lot of time to make happen. And I guess first of all, our model performance results are all coming from Alberta still. So we are trying to validate in other jurisdictions outside of Alberta, including here. And like I said, bringing the technology to the point of care is quite difficult. Not necessarily because it's technologically difficult, but process-wise, risk mitigated procedures that are in place at the hospital and so on will add to the timeline. And going to the prospective real world evidence that we want to generate. So these are the prime questions that we are trying to answer. Will clinicians trust and use Revaz AI? I mean, the results might look promising and great, but it doesn't mean that the physicians will use them and follow them and agree with them, right? So, we need to understand, first of all, like, is there that friction in real world situations? If there is friction, then how can we mitigate that? Will Revaz actually influence any treatment decisions, right? So the results that I shared with you are theoretical results, right? Will clinicians actually alter their decision? I was thinking of putting in some stents, but Revaz says CABG is a better option. Will the clinician actually follow it? And if the decisions are altered, will they actually lead to any benefits or improvements in patient outcomes, cost savings, et cetera, et cetera? We show that in the simulation study, but it's a simulation. And will patients actually, show improved satisfaction in the shared decision-making process? Like, one big part of using or showing this kind of quantitative decision support information is you show them to the clinicians and the patients so that they can discuss. Okay, given these numbers, as a patient, these are my preferences for my life. Put everything together, I think this is the best option for me. So is that taking place? And is this kind of tool making that happen a little bit more easier, right? And at the end of the day, we need some randomized controlled trial results. Otherwise, we won't be convinced that this actually works. So, a lot of work. And we have been partnering with UHI for over a year now. And it's been great. And we are making progress. And very important external validation site, as well as a potential clinical trial site in the future, in addition to the Alberta sites. So that's what we've been working towards. The path forward probably looks like this, not a straight line, not easy. Like in medical technology, software is very difficult. AI is more difficult. Decision support is very nuanced, and like I said, like, just because you bring that support information to the point of care doesn't mean that anybody will pay attention to it or do anything with it. So there's a lot of complex layers there that need to be figured out. And it's a really long runway. Like, how long will this whole thing take? We've been already working on this many years, probably more years to come. So, it's all about endurance and perseverance sometimes. And the good thing is I'm not doing it by myself. I'm here speaking about these results, but I'm definitely not the one that did all the work. Not possible. I don't have the expertise. So kudos to my teammates who bring their expertise and experience to the table. And a really big thank you to all the collaborators at the UHI as well. So that's the end of my presentation. I'm going to take some questions.
That was wonderful. That was very, very interesting. I think I personally have a lot of questions. One of them regarding sort of those last thoughts that you had at the end about all the big ones, like will it matter? Will it improve outcomes? And I'm wondering if you foresee that there's I don't want to say the younger generations of clinicians, but maybe a bit of like we're just, yeah. So I think you know where I'm going with that. So I'm just wondering if you have a perspective on that.
Yeah, based on my personal experience, there's definitely that generational difference.
Yeah.
I mean, like no offense to anybody, obviously, right? Like if I were like 60-year-old physician and I'm gonna retire in like 5 years,
Yeah.
why would I bother learning this kind of complex new thing that has not even been proven yet, right? So I totally understand that. And the younger people will probably be a little bit more tech savvy and they want to see whether this will improve something, right?
Right, right. And even just wondering like more about their own, all of us come with our own biases. So
Yeah.
obviously I believe, if I've been practicing this many years and decades that whatever I am doing to make the decision for the patient is the best one versus something else. So just wondering from that perspective too. But yes, I'll pat it.
Thank you so much. Can you guys hear me? Yeah. Thank you. That was excellent. I have a few kind of like what's under the hood of the model questions. Do those top-down models handle both time varying and time invariant parameters?
Not natively.
Okay.
So they are supposed to work on like cross-sectional tabular data. But if you can structure your data set in such a way that each column is an independent feature, then it will work. But the time varying stuff, you kind of want to like process it yourself and then just make sure that it meets what TAPPFN is expecting to receive.
Yes, that is implementation challenges.
Yeah, that's right.
Okay. Okay. And then also I'm wondering about, I guess, the precision of the model if you're a male or a female. And I'm imagining, I don't mean the underlying input data is like registry data, right? So the women are probably older and more frail by the time they get referred to surgical intervention. And so how does it handle that? And how does it define parameters that are a little bit more sex specific?
Yeah, it's a great question. So the models just handle it by having sex as a variable. So simple. But of course, that's not enough. And in our data set, only about 25% are female. So quite male dominant. Not surprising, right? So there's a bias to begin with. And then if you look at how the female patients are taken care of, they're quite different from their male counterparts. We actually have an unpublished study that is actually going through a peer review right now from the reinforcement learning study that actually looked at developing a policy based on females and then apply it to males and then vice versa. And that study really showed that the females are not being like getting the right care, right? So like yeah, like it's disturbing to see the results. Not totally unexpected, obviously. In the CJC paper study, what we did was we at least like assess the algorithmic bias. So is the prediction performance quite different between males and females? And if they are, then we did some post-hoc correction. So if it's a female patient, then we are gonna move the threshold of the model output to make it a little bit better. So again, it's a limited approach, but I pride myself for at least trying to do that when most other studies don't even do any algorithmic bias analysis.
Peter Liu, so congratulations. This is fantastic work and a very important foundational piece, as you mentioned, before the whole field takes off. And this underscores, the value of the approach database, which, we work a lot, in C-Core and many of the other networks, in terms of the value of having this type of longitudinal database, for the whole province. I think it's really virtual for Alberta. I guess one comment and one question. One is that I definitely think, even though it's a big mountain to climb, to actually aim for randomized trial. So the thing about AI is that, a lot of algorithms and the fantastic results, beautiful AOCs and things like that. But the adoption less than 1%. Part of the reason is that as a physicians, we practice based on evidence-based medicine, not belief-based medicine. And, we have a lot of faith. I'm a big fan of AI, but at the end of the day, it's not the evidence that's important. That's right now less than 0.5% of AI publications, or randomized trials. But things are coming, right? So in terms of cancer detection and things like that. So I think it's really, really important for everybody to work together towards that goal.
Yeah.
And that will be, sort of for the evidence that you need, that this actually does make a difference. The question actually related a little bit to what Jody mentioned earlier. We use a lot of AI in imaging, thanks to people like, Rob DeCamp and others, really actually very, very helpful for us to actually in terms of decision making. But we need actually the details. This is always the explainable component, versus the non-explainable component. So in addition to sex differences, we make a lot of decisions in revascularization based on status of diabetes, because the data actually tells you there's a difference. And also in terms of the ethnic background. So whether you're South Asian, versus European, Black, etc. So we take those things into account. And so, so if there is, so I don't know in terms of, using the, the engine that you have, in terms of the ability to adapt, for that patient just sitting in front of you, to actually put in those parameters to make that recommendation. Just wondering, whether there's enough data in there to actually allow us to do these individualized decision making, which is, real on the clinical front.
Yeah, thanks for those comments and questions. We definitely have diabetes, so we have that covered quite well, I think. Ethnicity, we don't have that in the approach registry or any of the other ultimate databases that we link to. So we just don't have it. But in like a future, prospective trials that we're currently designing, they will definitely collect ethnic, gender, even like indigenous status, all these variables will be collected to see whether, some of these marginalized groups don't get the same performance, or they, just have very different outcomes and they get very different treatments and stuff like that. So yeah, we'll investigate the future.
Thanks very much. Congratulations on all the work you're doing, and thanks for coming.
Thanks so much.
I have a couple questions, and I missed the first part of the presentation. Did you talk about what the impact on changing decision making is with the AI model?
Yes. So what the AI model does is it produces counterfactual predictions as well. So when it varies that treatment predictor variable that goes into the model, that will change the predicted risk, right? So based on that, it shows different risk levels depending on like what treatment is.
So what I mean is, did you look at how it would have changed decisions, like whether the disagreement rate, what was it, around 70% disagreement, and what the okay.
Yeah.
So you did mention that it was based on retrospective data.
Right.
You talked a little bit about the gender sex bias, but obviously retrospective data has bias.
Yes.
How did you account for that?
Yeah, and that's all the limitations coming from retrospective studies. We cannot really account for that, completely, and and this just becomes a major limitation of retrospective studies, and that's just sets up the stage for needing some kind of prospective trials to really see that. So again, like there are a lot of different like dimensions to that. Like there's a lot that has to do with the treatment feasibility, right? Which I sort of spoke to, and like given a patient, if that patient were given a different treatment, let's think about what would have happened to the patient. So that's the counterfactual part. That's difficult with retrospective studies. And a lot of people will actually say you can't even do it with the retrospective data, right? So that's, again, that's something to be examined in prospective studies. But I guess what we are trying to hope for is if your data set has enough clinical practice variations in the data set, then maybe there's something that can be learned. So what the model will try to do is, given the same patient characteristics, if I just change the treatment, what's the impact on the predicted outcome, right? So if the model has seen a lot of different patient cases that are all over the place, right, then the model would have seen something like that and then would produce something that's quite believable or accurate. But as we all know, in clinical practice, there's a correlation between what treatments the patients receive based on their characteristics, obviously, right? So like how much variation is there in your data set? So I think that's the question that boils down to. And another thing that I'm going to mention about that is, so this is where like machine learning technology might actually help a little bit. So if you think about large language models, they're known to perform really well on questions that it has never seen, right? So we machine learning, we call that zero shot or few shot learning. So zero shot meaning had actually never seen anything like that before, but if you ask it the question, then it actually performs pretty well still. So these are the capabilities of like transformer-based LLM-like models. So the TAP-PFM model that we used is one of those. It belongs to that family. These need to be validated, but they have some potential to perform quite well when it comes to counterfactual predictions.
So to build on what Dr. Liu asked about the randomized trial.
Yeah.
So I would agree, you want randomized trials, but having tried to do trials where you're using something like imaging that impacts information that leads to an action that leads to a treatment.
Yeah.
You're several steps away, and this in itself doesn't change the treatment, right? It's changing a decision, and the decision may be good or bad, right?
Yeah.
Yeah. Even if it's right or wrong, right? So what I would say is you do need all that prospective data to build the case for it, because you also have to create the equipoise.
Yeah.
Because people have to believe that it may or may not help, and that you just don't know.
Yeah.
And that they're willing to actually change a decision based on what you're doing.
Yeah.
So I just add that point of caution.
Yeah.
As well, because the number of patients that you may need may be quite a bit higher than you think.
Yeah.
So just to keep that in mind as you go forward.
Yeah. Thank you so much for that. Yeah, definitely.
Hi, thanks for coming. Ian Patterson, I'm an imaging cardiologist. So I know James White and a few other people. I worked in Edmonton for many years.
Oh, okay, great. Yeah.
So I recognize most of the names you put up there. So just a question about which you kind of answered in part. What I'm wondering as I hear this, I think a lot of times, and you can correct me, the model may disagree with what actually was done in terms of decisions. So two things that come up a lot in clinical practice are how feasible is it to do the intervention? So sometimes there's technical issues, like for example, on bypass, if the vessels are too small to bypass, or too small to put a stent in, because technically you can't do it.
Right.
And then risks as well. So you alluded to this when you talked about frailty. So you can calculate what is someone's risk to have a bypass surgery, and sometimes that sways away from bypass and towards revascularization, for example. So these would be important things, I think. Maybe your model incorporates these things, but it might, like when I saw, the disagreement rate between your model and what actually was performed, these are the things in my head that probably informed on that disagreement rate. And you could actually go back and look at the ones where there was disagreement. Maybe there are too many, but you could look at a subset and see, okay, what was the reasons for the disagreement? Was it due to technical factors? Was it due to risk? And try to build that into future iteration. I think it's very important to get the model right before you start doing the prospective studies and the RCT. That would be my advice.
Yeah. Excellent points. And like we've heard this kind of feedback before too. So like from a procedural perspective, like is a particular treatment even a viable option? The information or the data that we use to develop the models lack a lot of these detailed pieces of information. So the models actually know a lot of these things. Yeah, so, again, I think this is like one of the good reasons why it has to be investigated further, preferably prospectively. And like in our clinical trial designs right now, it includes things like, concordance between the treatment that the physician was thinking of and the actual treatment or the suggested by Revaz. And also, if you're going to reject what's being suggested by Revaz, what's the reason for it? So we'll have to collect the data and then really understand. Yeah.
Again, I'm perseverating on this women's issue.
Yeah.
And quick idea, I was wondering, it makes me think that truly what you need is a model for primary care that evaluates women like 5 years earlier than the point
Yeah.
that they're entering into this model.
Yeah.
And so I'm wondering if there is the thought of kind of expanding the application of this and having a tailored version more for primary care with other kinds of factors. And then the decision isn't treatment, it's referral, like to subspecialty. So anyway, just a thought of like kind of broader applications of this type of model.
Excellent points that we've been thinking about that too. So bring it upstream, focus more on prevention as opposed to therapies. So yes, right now we are using data that are coming from cath labs. So the patients are already there. Things have progressed quite a bit. So that's the data set we're currently using. But some of the predictor variables that we're using are not coming from acute settings per se. They are actually available for rather long period of time. So you can start to think about pushing it upstream a little bit, and when is the earliest point that it can fire, and then provide some useful information. So yeah, all great suggestions. And I mean, even before the patient gets to the cath lab, the one immediately before that is like what imaging modality are going to acquire for the patient. So CTs are becoming a lot more common now. So there are some researchers who are working on triaging between CT and coronary angiography too.
Okay, so I think that concludes all of the questions. Thank you very much. Katie had to run to another meeting.
Okay.
So thank you very much, and I'll hand it over to Adam to introduce the AI demo session.
Thanks very much.
So I've had the pleasure of working with Arjun and June over the last year to strategize on collaboration and how we work with them as academics, but also as partners. And it's my pleasure to introduce Arjun to the podium to give us all a real world live example of what their academic work has led to from a commercial perspective.